Hi, everyone. Welcome. Thank you for joining us today to hear a bit of real talk for the realities of being and becoming an IBCLC for physicians. My name is Angela Love-Zarenka, and I am with Lactation Education Resources. Our special guest today is someone who knows a great deal about becoming an IBCLC as a physician. Dr. Weinhold, Dr. Sally Weinhold, is a family physician working in Ithaca, New York. She's a graduate of State University of Buffalo School of Medicine and Biomedical Sciences and completed her residency at UHS Wilson Hospital Family Medicine Residency. As a family physician who commonly takes care of both the infant and the lactating parent, she is able to troubleshoot breastfeeding difficulties from both sides of the puzzle to help infants and families grow and thrive. Part of her interest in breastfeeding medicine and helping infants grow and thrive comes from her bioengineering training before medical school. Babies are just tiny, complicated bioreactors that need all the right factors to thrive. She's excited to help bring more physicians into the world of evidence-based breastfeeding care. If you're watching this recording on YouTube, post your questions in the comments below and we will reply. You can also contact our amazing customer support team at support@lactationtraining.com. Okay, so let's dive in and take a closer look at what a lactation consultant is and how you can follow your passion and become one. If you decide to become an IBCLC, you will join more than 32,000 IBCLCs in over 122 countries and territories. Credentialing as a lactation consultant is offered by the International Board of Lactation Consultant Examiners. Take a look at their website, IBLCE.org. They have different regional offices depending on where in the world you reside or work. Review the requirements and pathways to become eligible to take the IBLCE certification exam. What do you need to know? The detailed content outline or exam blueprint is based on surveys of IBCLCs in various practice settings around the globe. The outline covers all the topic areas and the chronological stages an IBCLC needs to do their work. The outline LER courses cover the entire detailed content outline, and our courses are approved by LARC. That's the organization that evaluates and approves the lactation consultant training courses. So now, without any further hesitation, I'd like to turn it over to Sally. Sally, go ahead. Tell me, why? Why should people become an IBCLC if they're a physician?
Well, I'll start with a little bit of why I made this journey. I had my first baby 4 years ago as a third-year resident. Delivery was uneventful, latch was fine, but really, really painful. I asked to see a lactation consultant and was told, oh, all the nurses do lactation support. Several in the past had been IBCLCs, but it was too expensive and burdensome to stay certified, so there's no IBCLC available. Don't worry about it, you'll be fine. They sent someone to my room who grabbed my breast, stuffed it into my daughter's mouth, said, latch looks fine, and I was definitely sure it was not fine. It was very painful, trying not to wince. When I left the hospital, I had bruised nipples, one was bleeding. I told myself I had to do it for 2 weeks, and at that point, I could make a decision. I happened to be visiting my mother for her birthday, and we went to a La Leche League meeting at a local library. And the leaders were amazing. The dyads there were very kind. They were supportive. And I just looked around and said, if everyone else can get to the point of gymnastics with toddlers, certainly I could too. And I started doing those late night Google searches. Why are my nipples turning black after I nurse? Is 15 ounces of breast milk enough to send to daycare? And that really sparked my interest, realizing how much was out there and how much wasn't out there realistically. I tried to do an elective when my baby was about 4 months. In lactation, and I was denied by my program. So I said, you know what, we'll put that on hold and we'll get there. When I started my attending job, one of my colleagues and friends connected me to Dr. Milk, which is an online physician-only support group to help female physicians meet their lactation goals. And that was kind of the turning point for me. I was really hooked at that point. I spent tons of late night nursing sessions reading, learning about all the catastrophes that can happen, learning about common problems. I eventually became a moderator and served one of their one-year terms as a moderator, and then stayed on as a past moderator to help and advise new people serving as moderators. Somewhere along the way, my boss introduced me to Diane Wessinger, invited her to one of our staff meetings to encouraging me to attend the IABLE, which is the breastfeeding conference. That's really, really awesome resource. And kind of along this process, I realized that our town is really high in breastfeeding rates, and that we needed someone who is an MD or DO to help support this. And so I decided it should be me. So then we kind of, next slide, perfect. From there, it was kind of, why do we need this doc? Or that was my next thought. And it's because everyone breastfeeds in town. I have very few patients who do formula feeding. But the best MD support is actually like 2 hours away for us. So having something local would be a much lower barrier to care for the brand new mothers, for the brand new babies, because driving and getting everything coordinated to make that trek was quite a pilgrimage. Locally, we have a ton of really good IBCLCs who work with and support many of our lactating patients, but almost all of them are private pay. There's a few who work in the hospital, so patients would get care while they were still admitted, but then once they were discharged, not have that much support because they weren't able to afford the IBCLC. There's one or two who work with WIC, but certainly through the pandemic, they're nurses working at the health department, so they're doing other things. So as a physician, I'm able to bill insurances and work with insurances. So it's really affordable to my patients who are on Medicaid or other state insurances. So both more affordable, and then also having a little bit different approach and a little bit different skill set. That there's a lot of big picture difficulties that our IBCLCs are great at working on latch. They're great at detecting that there is a problem, but not necessarily able to have those solutions. So coming from medicine and engineering background, I love the numbers game. So how many grams per day is that baby gaining? You know, when the lactation consultant says this baby's really struggling, then turning it into a, first of all, are they struggling? Second of all, how much are they struggling? How many ounces should we be supplementing, either pumped milk or donor milk or formula if need be? Trying to figure out, you know, when to do the next weight check, how to alter that nursing relationship in a way that becomes more satisfactory and more fruitful with helping the baby gain weight. Some piece that may or may not be relevant in all communities, but a lot of times becoming a lactation consultant doesn't require as much math skills as physicians need. Between kind of all the training and to get into medical schools, often you have to take all those math courses in college. So having that as a background, you may be in a better position to be doing those calculations with parents than necessarily a lactation consultant who's not a physician. Family physicians are really well seated to be able to see both the babies and the parents, which I think is great. But there's a huge role for IBCLC physicians who are not in family medicine. Even if you only work with half of the dyad, you still can contribute a lot. So certainly recognizing that there's an issue is half of the problem. So seeing, if you're a pediatrician, seeing that baby who's struggling to gain weight. If you're watching a breastfeeding session, you may be able to recognize something like insufficient glandular tissue in the mother. And even if you can't address it, you can at least know what are the things that you'd be looking for, or you know, what resources might help that dyad. You may be able to recognize that there's mastitis going on and tell the mom, yeah, you really need to get to the doctor to address it, versus, you know, that may or may not be something that one's looking for if one's not specifically looking breastfeeding medicine wise. You may not be asking to watch those nursing sessions. Also, you can look at a mom's med list and be concerned. And again, you may not be able to change her medications, but you may be able to say, lithium's maybe not the best med. Let's see if you can talk to your psychiatrist and see if Lamictal's an option, or kind of addressing some of those needs as well. Someone who's a mom doc only, gynecologist or other fields, may be able to see something like a tongue tie if you happen to be looking, you know, have the baby there at the appointment. And then certainly even outside of the fields that we think of as caring for moms and babies in general, you can still support protecting the nursing relationship when a mom is admitted. So if a mom's admitted for pyelonephritis, making sure that antibiotics are compatible with breastfeeding if able to, making sure that there's a pump available. If it makes sense, seeing if there's a way to get baby in to physically be nursing for some of the times. Again, probably not in the pandemic, but realistically, most of the rest of the time, there's options for baby coming in during visiting hours if there's a dad or a partner or a family member who's able to help supervise that situation. Making sure if a mom has to undergo surgery that there's support, and checking to make sure that the medications are reasonable, giving evidence-based recommendations for what to do post-procedure. Most times moms don't need to pump and dump. However, that's very commonly recommended and can be very terrible for the nursing relationship versus being able to just latch that baby directly. I think also the knowing what resources to direct parents to is important too. So that's also a piece of it. Then moving on to the next slide, different pathways that you can go to get through IBCLC training. All of the pathways need basic science classes. So those are things that probably you had in college or through medical school. Then you have to do 90 hours of lactation specific education. That can be done through in-person training, that can be done through online training, tons and tons of options for that. And then you need to get lactation experience, and that differs a little bit based on which pathway you're doing and depending on whether it's supervised or whether you're doing it practicing under your own license as a physician, which is what I did. So I had to have 1,000 hours, which is a lot, but also a lot of it's stuff that I do in my daily practice without even sort of thinking twice. So really counting the time that you're already spending taking care of those dyads or triads is really important. Then let's go to the next slide. So this is kind of the different tasks that I use, or the different categories of hours that I collected. Being a moderator for that Dr. Milk online support group counts towards those hours. Specifically, it was helping troubleshoot difficult latches or trying to help moms transition into pumping and getting to being successful breastfeeding and working parents, which is a very big deal if that's something you've been through. I was able to count some of my hours within residency. So working in the NICU, we were doing tons of calculating growth intake, very detail oriented. We also had several babies who were admitted when I was on the inpatient pediatrics rotation doing, who were admitted for failure to thrive. So trying to figure out what their needs were and how to meet those needs was really important. Had some continuity patients in residency who were breastfeeding, and so that was something that we definitely talked about and addressed. So some of my hours came from there. Also, when you're catching a baby and doing postpartum visits, definitely hanging out laboring with a mom, definitely some of the conversations about breastfeeding came up, and I think that was also a really different and important piece of my training. And then the bulk of my hours have actually come now in my current practice because so many of our moms and babies are lactating. Or are lactating or nursing. So thinking at a well visit for a mother who's maybe 42 and has a 5-month-old that I want to order a mammogram for. There's definitely, important discussions of saying, yes, it's safe. Yes, you can breastfeed right afterwards, but also making sure that she empties her breast right beforehand to be getting as good of imaging as possible. Things like antibiotics for any women in their 20s or 30s who I happen to know as a baby or as a mother because I see their baby. It's important to me making sure that we're making the appropriate choices for medications. And also is there a question?
I just had a quick question though. What about your own personal breastfeeding hours? Can you count those towards your clinical hours?
I wish. No, you can't that I am aware of.
Yeah.
Otherwise, one would get to be way too many too quickly.
Yeah, that's true. You would have it. That would be a slam dunk. Yeah.
Yes,
So
yes. I mean, having a 1-year-old, you'd be set.
that's true. You'd be so set. Yes, that's true. So good. I'm sorry. I didn't mean to interrupt you, but there was that
That's
question.
all right.
So thank you.
Yeah.
Thank you.
Yeah, I wish that they counted at least some of those hours, even if it was only like 50 or something, it would be wonderful, but they don't. So it's really just kind of looking and seeing where within your day you're actually interacting with the act of nursing and breastfeeding and lactation. Um, and it comes up more than you think. As a young female doctor, I think I tend to see more young female patients even amongst my adult population. So it comes up more for me than maybe for some of my colleagues. But it's really, realistically, it's an estimate of trying to figure out and piece together where those hours are coming from. My next slide here is talking about those 90 hours of education or breastfeeding specific education. So I had the delight of going to the IABLE conference in 2019, I believe. I could be wrong on the date. And it was probably one of the best experiences. I've never been to a conference before where it's okay to bring your baby and sit and chat. And, you know, if a mom who had a baby who was there needed to pop up for the bathroom, they just pass you their baby, go do what they need to do and come on back. You know, people were breastfeeding through it. There was hands-on demos of different things. There was lots of interaction. Just a really fun and really, really useful course. I then did a handful of the LER lectures and other random lectures, just kind of picking off different topics that I thought were interesting. Some were through the public health of University of Albany that had some really interesting things. So like breastfeeding during public health emergencies or breastfeeding implications in different social and cultural groups, which I thought were really useful. And as I was coming close to that deadline to register for the exam, I said, you know what, I'm just going to do one of the LER courses to finish those hours. And so I just did it. It was, you know, a lot of slogging through, but certainly nothing different than what you all did to get to where you are right now. And then there's also the communication app. Oh, go ahead. Question?
So you were going to say the communication hours. Go ahead
Yeah.
and finish with the communication hours, then I have a question.
Yep. The communication hours are a new requirement that was added in the past year or two, I believe. So talking about how you should be talking with women about lactation. And I say women, but also in general, a big piece of it is addressing and being sensitive of people who are transgender, who are in a nursing or chest feeding relationship. So trying to figure out what's the best way of interacting with a broad, diverse population that we see in the lactation community. And for that, I decided randomly, let's pick a different course than what I've done all of the other training, just to get a little bit different opinion or side of things. And so I did that 5-hour course as well.
That's good. No, there was a question about whether or not was getting CME as well. Were you able to get CME for those hours,
Yes.
all of them, or okay, good, great.
Not all of them, but most of them. And it wasn't necessarily a one-to-one translation
I see.
for all of them. But realistically, yes, I fulfilled my CME needs for the year, or well, for the past 2 years, in addition to some other looking at other interesting topics. But realistically, most of my hours that I did for IBCLC also count as CME hours for family medicine. You have to look a little bit to make sure you're picking an option that works for that. Some do, some don't. I feel like the public health of Albany maybe counted, but not for as many CME hours as they counted for the lactation education hours. And then the biggest thing was studying for the exam that I was just going through earlier this year. I actually took the exam in September and won't find out if I passed for a little bit yet. It can take, I think, 12 weeks or so to get the results back, which is just like all of the exams in medical training, nerve-wracking, but that's the way it is. I found it was very similar the way that I was studying. I found I did a ton of question banks because I think that that's just a good way of getting used to organizing and presenting your information. I also was re-listening to the LER lectures, especially the topics I was less confident on. There's a really good breastfeeding atlas that has a lot of images that are similar to the images that they use on the exam. So it's nice to just kind of look at it because you find yourself staring at a grainy image saying, what is this? and trying to look and figure out, because it's on a computer screen. Think about, it looks like cell phone pictures from the 90s practically, of just like those early, snapshots that you're trying to figure out. Okay, is that breast red? Yeah, okay, it's probably mastitis based on the question stem. But just kind of reviewing through those pictures was a really good help for me. I also used the Lactation College, which was a free online resource. There were things that you could read, so summaries of topics, but then also they had questions that went with each of them. So I did the questions first, and if I did really well, then I skipped reading their summary. If I was struggling, then I would go and read their summary and kind of go through it again. There's also a bunch of sort of Facebook or online groups for people, not just MDs, but general people studying for IBCLC exam. Those were kind of mixed benefit. I think there's a lot of alarmist, at least I'm hoping it was alarmist, about people needing to retake the exam 2, 3, 4 times. So I'm hoping I don't fall under that category. But also just kind of sharing resources or saying, hey, here's a free place to go and get stuff. That's how I found out about the Lactation College, which was pretty cool. There's a group, oh, go ahead. Oh, there's a group that I used as well that's doctors practicing breastfeeding medicine or wanting to, is a Facebook group open to physicians, which I think was a nice resource that I got sort of my jump start on figuring out how do you even go about collecting hours. What types of resources are there for getting the lectures or the education piece. And then it's also a resource for people later or going through this process to bounce questions off each other. If I have a dyad that's struggling with this type of thing, what thoughts do you have, or what are other techniques for plugged ducts that I might not have thought of, things like that. And go ahead with the question.
Yeah, so there are just a couple of questions here, if you don't mind answering them now.
Yeah.
Somebody asked somebody just completed their first year as a pediatrician attending. Can time spent
Okay.
on the newborn nursery and NICU as a resident be used towards the 1,000 hours?
Definitely. You have to do it your hours can count within 5 years of taking the exam. So depending, if you just graduated, you certainly can count those. I was only able to count some of my years in residency because of just when I was going through the process. But if it's within 5 years and you have a bunch of hours, go for it. I think I struggled a little bit more with getting those hours because my family medicine residency, most of our patient population was not breastfeeding. So it was more of after I graduated getting that time. For me, getting those education hours was easier. I know some people are the reverse, that they get tons and tons of those hours in the newborn nursery working with dyads. And then they have to like catch up and do the coursework afterwards.
Right, exactly. Good, good. Well, and there's another question here. Someone works in a family medicine clinic, in the breast surgery clinic, and in surgery clinic, I counsel about breastfeeding often, but aren't all actively breastfeeding. Does that count?
That's a good question. I believe it would, because it's counseling relating to lactation.
Correct, yeah.
And I mean, I do preconception counseling all the time. I don't follow obstetrics patients, but it comes up sometimes if I'm at a well woman exam and someone happens to be pregnant, I bring up, hey, what are your plans for feeding your baby? And often the case is that it's breastfeeding. And so we talk about it. We talk about things to do to get a good start. I always let them know that, like, this is what I do as well. So bring your questions to me too. Sometimes it's tough to get in to see the gynecologist, and definitely within gynecology training, there's a huge variety as to how much training they got of breastfeeding medicine. Less of the focus tends to be on that end of things.
Right, good. And then the last question for now is, did you ever do any shadowing with an IBCLC?
I didn't. I had been planning to and hoping to in residency, and then when that elective that I was going to do was shot down, that all kind of went to the wayside. I
Which is a
certainly have
shame.
IBCLCs now that if I wanted to, I could hang out with. I always tell students that it's good to have both of us on their team, that the IBCLCs probably have more experience in working with the latch, and that I would be their resource for the medications or some of those sort of tougher, more global issues to be working on. So
Right.
people who have that ability to see the private lactation consultant often see both of us. The people who don't, then I'm 100% better than not being there.
Yes, yes.
Most of my experience working on latch is with my own babies and also with friends' babies, realistically. But those hours helping friends out didn't count towards my 1,000 hours,
Right,
but definitely
right.
helped with my mental skills and knowledge.
Absolutely. No, anything you can do in order to feel confident. And that's really the reason for those clinical hours, is to help you to feel comfortable and confident to be able to support families once you are board certified. So that's the reason for those clinical hours. So that's really helpful. Thank you so much. Is there anything else you wanted to add, or maybe think about it and we can address it at the end? I'm going to kind of
Yep.
run through real quick if everyone wants to follow along here. I thank you so much for that story. Your story was really helpful. Knowing how you did it personally is so inspiring. So thank you for your persistence in being able to support families. And so now I'm going to talk about the actual how-to, and it's the roadmap to becoming an IBCLC. And for some people, it may feel a little complicated, but I'm going to break it down and give you a sort of this roadmap that you can follow in order to become an IBCLC. So there are 3 different buckets that you need to take a look at. And one has to do with the education, the other has to do with the clinical hours, and the third is exam prep. So the first component is this health sciences education, and it's typical education for a healthcare provider. So as a physician, you've already met that criteria. The second thing is the lactation specific education. This is where LER has you covered. The education should be comprehensive and cover the entire IBCLC detailed content outline. They require at least 90 hours of lactation specific didactic information and 5 hours on communication skills. Our 5-hour course is specific to lactation and breastfeeding care and can help you in your practice as a lactation consultant. The third component is that lactation-specific clinical experience. This can include in-person consultations, telephone consultations, or online breastfeeding and lactation care that supports breastfeeding and chest-feeding families. Also, it includes lactation assistance to pregnant and breastfeeding clients and lactation education to families or other professionals. These hours are to be obtained within the 5 years, as Sally said, immediately preceding applying to the exam. And so how many hours do you need? Well, that really depends on which pathway you choose. So there are 3 pathways, but pathway 1 or 3 are the 2 that most physicians will use. The amount of clinical experience required to sit the exam depends on this pathway. The hours need to be accrued, as I just mentioned, in the 5 years prior to applying for the exam. And here's a sort of quick overview, and I'll get a little bit more deeper in detail in just a few minutes. Pathway 1 is for healthcare professionals and those who provide breastfeeding support through an IBCLC recognized breastfeeding support counselor organization. Pathway 3 is a structured mentorship program between the IBCLC and the student. The IBCLC or IBCLCs must be in good standing with IBLCE. So those who choose this pathway must have their program pre-approved by IBCLC prior to beginning their clinical hours. And I understand that's relatively quickly these days. A quick note for those of you who have, as Sally just mentioned, if you've breastfed or chest fed or provided human milk for your baby, unfortunately you can't count those hours. While 500 or 1,000 hours seems like quite a bit, there's a good reason why. And as I mentioned before, it's to make sure that you feel comfortable and confident supporting families. Now, if it's any consolation at all, those clinical hours, it used to be many more. I've known IBCLCs who needed anywhere from 2,500 to 8,000 hours, clinical hours before sitting the exam. So candidates who are applying for IBCLC through Pathway 1 need at least 1,000 hours. For the candidate who's also a healthcare provider, the hours can be done in a hospital, birth center, clinic, lactation clinic or practice, a primary care practitioner's clinic or practice, or through an independent practice as a licensed or registered healthcare professional in a non-healthcare setting. So what counts, as I mentioned, the prenatal education, any sort of counseling about breastfeeding, and the lactation-specific evaluation and management. So 2 important points about this pathway and the clinical hours. It's important for you to document them as you accrue them. Be very detailed in case IBCLCE chooses to audit your application to take the exam. They may want to see documentation such as a spreadsheet or other document where you counted your hours. Remember that Sally had that spreadsheet and she could catalog the specific amount of time she spent counseling and managing lactating people? That's a really good idea. And the 1,000 hours do not need to be directly supervised. Now, if you decide to go pathway 3, that requires 500 hours of clinical experience, and this must be directly supervised by an IBCLC in good standing. And it's best done in a busy practice where you can work with many breastfeeding, chest feeding people, and those providing human milk for their babies each day, such as a hospital or clinic setting. And you do need to have that application approved in order to go through pathway 3 prior to accruing your hours. Now note that the 500 hours are those hours when you're actually working with families. Now remember that there's going to be a period of observation prior to beginning to actually support families, and those hours do not count. So how do you find an IBCLC who's willing to mentor you? Take a look in your community. You may need to reach out to many people in order to find someone with the time, experience, and capacity to agree to be your mentor. It's important to find that good fit. Talk to others who've been through pathway 3 to find a successful strategies with a good mentor. And I think that the Dr. Milk listserv may be a good place to find people who may be willing to mentor, or how other physicians were able to work with an IBCLC. So as I said, this does need to be approved prior to beginning to accrue your hours. Go to the IBLCE website and you can download the guide. The link for this is actually in the handout. And as I mentioned before, if you are having any difficulties in obtaining the handout or have any questions, you can reach out to us at support@lactationtraining.com. And now some people will wonder, well, gee, why should I do this hours? It's fewer hours. Why should I do this pathway? You know, it's fewer hours. That sounds really attractive, but jumping through the hoops to find that IBCLC is a bit challenging, and it may be discouraging. But remember that one of the advantages of doing a pathway 3 program is that usually those candidates score better on the exam than people under pathway 1. And so I think that mentorship piece is that key component. And so if you can have an opportunity to work with an experienced clinician, either through pathway 1 or pathway 3, you may find some advantage to it. So clinical hours. There's this special time now that we're all living with the pandemic. And so a lot of people are asking whether or not they can accrue their clinical hours via telehealth during the pandemic. And the quick answer is yes. Now, I'm actually going to take a minute and I'm going to read this information from the IBLCE. And specifically, they say, quote, during the SARS-CoV-2 pandemic, IBLCE published specific guidelines about attaining clinical hours when face-to-face interactions were curtailed to reduce the spread of COVID-19. If you go to the IBLCE.org website and go to the COVID-19 page, you'll find all of this information there. And it's dated both April and October of 2020. IBLCE will allow the use of technology if certain parameters are met and allowed by your practice setting and by the IBCLC guiding practice documents, such as the scope of practice, the code of professional conduct, and the clinical competencies for the practice of IBCLCs. The key provisions include attention to privacy, security, assessment, demonstration, and evaluation of relevant techniques, provision of evidence-based information to clients, as well as appropriate collaboration with or referral to other healthcare providers. Particularly emphasized is Principle 3.2 of the Code of Professional Conduct, which requires advance written consent from the breastfeeding parent prior to photographing, recording, or taping, either audio or visual, the parent or the child. Another important point about the use of technology for pathway 3 interns is that there should be, quote, observation using technology with two-way synchronous audio and visual components. The focus is on the mentor providing the mentoring and guidance to the applicant. And pathway 3 candidates can earn 100% of the minimum of 500 clinical hours through technology platforms. And so it's important to read all of the IBCLC documents listed in the interim guidance before you begin to utilize telehealth to ensure that you've got all of those I's dotted and the T's crossed. So the education piece. At LER, there are two ways to gather your lactation-specific education. One is the Lactation Consultant Training Program, which is the full 95 hours front to back. The other is either the core or the bridge course. They are designed to meet your education needs depending on your background and previous lactation training. First, we have the comprehensive course called the Lactation Consultant Training Program. LCTP is a 95-hour course which is eligible for CME. It's intended for those who do not have any lactation education and they want to know how to become an IBCLC. Or actually they've made that commitment and they want to become an IBCLC. As mentioned before, it covers all the topics from the detailed content outline. And in the coming weeks, we'll have a course option that awards CME, meets the 95 hours of lactation-specific training for IBCLC, and includes a gift card as well. We have more than 35 of the most knowledgeable, experienced instructors who are practicing lactation consultants, physicians, researchers, and authors who teach in our courses, including Sally and me. Our classes are economical. You can view them on a variety of devices such as your computer, tablet, or phone. They are optimized for a computer, but they can be reviewed later when you're on the go. Using an online platform, there is no travel to another city, hotel expenses, leaving your family for a week, or taking time off from work. Furthermore, our online course is convenient. You can study at home at a time that works for you. You can study at your pace, even go back and review something you didn't catch the first time through. Now, everything is crammed into a short period of overwhelming intensive study. Now, we actually taught in-person training courses for over 15 years. Students left the program dazed with too much information condensed into such a short period. We think that spreading out the classes helps with comprehension and retention of the information. Work on the modules whenever you have a small window of time available, and you can integrate the information into your practice as you go. If you have a question for the instructor or want to discuss a concept for your fellow students, there are several ways to connect and get the answers that you need. We have a very active Facebook group for those who are in the 95-hour core, bridge, or exam review course, where our students can meet each other and support each other along the way. And there are IBCLCs who are also in the group, both as participants as well as people who are keeping an eye on the chat and can chime in when necessary. The Lactation Consultant Training Program is the full 95 hours, but if you're not sure where to start or you already have some lactation-specific education, then our core or bridge programs may meet your need. Now, they have the same advantages as the Lactation Consultant Training course. So our initial course is called Core because it provides you with the core lactation education you need to understand what it means to begin to support the normal course of breastfeeding. It's 52 hours of online education. It covers the basics such as anatomy and physiology, infant growth and development, supporting the preterm baby, medications and breastfeeding, and many more. At the end of the course is a certified breastfeeding specialist exam, and that's the one that Sally took. The bridge course is ideal for people who have the basic lactation education components and need an additional 45 hours to qualify for the IBCLC exam. Topics in our bridge course include legal and ethical concerns for the lactation consultant, infant feeding and disasters, breastfeeding the infant with medical challenges, case studies, and clinical skills videos. So if you're not sure where to start, if you're new to the profession, I would suggest the core courses. Get your feet wet first and see if becoming an IBCLC fuels your passion. Our team is here to help you now and in the future. We have tech support, which is open 7 days a week. We get your questions answered by the content. We get your questions about the content answered by the experts in the field, and we have ongoing support for the next steps in your lactation career. Thank you very much for listening to our chat today. If you do have any further questions, please feel free to reach out to support@lactationtraining.com. And I'm going to see if there are any other questions that have come in during our chat. Sally, is there anything else you wanted to add?
Sorry, let me unmute myself. I see
Perfect.
one question that was coming up that as a pediatrician and planning to become an IBCLC, would I be able to prescribe meds to the mom, like for mastitis? And that really depends on your licensing and your malpractice. There are some pediatricians who absolutely do, and there are some pediatricians who absolutely don't. And it kind of goes the same direction of, if you're licensed to see adults, could you prescribe a med for a baby? And again, it goes back to what your institution says, what your malpractice carrier says. I think it's convenient if you're able to do both, but realistically, it's still such a great resource to the community, even if you can only prescribe for one direction, because the advice is really for the dyad itself. And the vast majority of what I do is not actually prescribing medications. It's on giving recommendations of how often to feed, when to feed, how to do a supplemental nursing system to be supplementing at the nipple, all sorts of different things that are maybe not medication related and are just specifically lactation related.
Hmm. Excellent. And then another question here. You said you did not shadow an IBCLC, that's right.
I did not.
And
Nope.
then there was another question about the hours. So what if someone is in surgery, is working as a surgeon? Where did that question go? Oh, yeah. What about if the surgery that is to be performed will impact breastfeeding?
So you
Are
can
those
absolutely
hours?
count the time that you're spent counseling on the impacts of the surgery for breastfeeding. I don't think you can, in good faith, count the hours that you're spent talking about the other, risks or aspects of the surgery, kind of everything else that goes into that surgical procedure. But
Perfect.
definitely, if you're talking about, here are your options for a breast reduction, and these types of incisions tend to be more likely to be conducive to future breastfeeding, or these are your options, that discussion absolutely counts towards the hours.
Excellent. Good. As a pediatrician, let's see, prescribed meds, you
That's the
got
one I
that
was
one
talking
already. Yeah, perfect. Okay, good. Yeah, I think we caught all the questions in the chat. So I think we're good. Any other comments? I mean, I really do appreciate you taking the time out of your busy clinic day. I know that you're in the middle of patient care right now. So thank you very much for taking the time to chat with us today. This has really been helpful, so helpful.
I think I just want to put it out there that it's a really fun and rewarding process. There's nothing better than getting to see a patient that I've struggled with or helped them with, their struggles through getting to a successful breastfeeding relationship, then seeing them back in 2, 3, 4 months, and the visits are fun, they're easy. Just getting to do those well visits for a baby that's thriving and knowing how much of a part of that I was.
Yes.
And seeing a mom who is really nervous about things and seeing her thrive, and that often, a lot of the mood symptoms and things just lift when breastfeeding is working. So it's beautiful, and it's a great part of my day to see those appointments on my schedule.
Right. Yeah, no, it really is nice. And I also agree with that. And, people need so many different avenues of support. And as a physician and someone who's seeing those patients, especially as a family medicine physician, you're seeing the parent, you may be seeing the partner, you're seeing the baby as well. And so really you see the grandparents. And so it's nice to be able to sort of have that continuity of care as a family practice provider, and also know when you need to possibly, say, you have limited amount of time to see clients, therefore, and to see patients. So it may be that they need more intensive support with a board certified lactation consultant. And I just personally have to say, as someone who works exclusively as an IBCLC, I really do appreciate the physicians that are in my community who are there to be able to support the dyad as well. So, or the triad, or however many, and especially for parents who choose to exclusively pump. The nice thing about you is that you're putting breastfeeding first, and the priority and why it's so important. So that's fantastic. There's a quick question here about if you want to reach out to Dr. Weinholt, please do email us at support@lactationtraining.com, and we will make sure to forward any questions or comments to Dr. Weinholt. And then news about recertification. So yes, we do not have any news. They are the guidelines for recertifying as an IBCLC. They are changing as of 2022. And just a little pro tip here. I am due to recertify in 2022. Therefore, I voluntarily and happily become one of the first people who need to go through that. And so as those details come forward, as we figure out exactly what to do and how to do it, rest assured that Lactation Education Resources is going to be on our game to make sure that we can meet everyone's needs. So thank you very much for attending a day. Thanks again, Dr. Weinholt. Really do appreciate your time. Thank you so much.
You're welcome. Good luck, everyone.
Thanks. Bye.